Hello, welcome and kumusta, and thank you for joining me. My name is Hao. I am your occupational therapist, and welcome to OT Conversations. In this episode, I am thinking maybe we should explore on the frames of references or models that you can use in critical care. How is that? Okay, cool. So we'll do that. We'll talk about the frames of references or models. So first, when you go and start working in critical care, you just have to understand that critical care is critical care medicine. It's intensive medical attention, intensive nursing. There is a lot of monitoring because you wanted the organs to work in harmony with one another. So we're looking at very sick people in critical care. And when they are sick, they can be sick to a point that they needed to be sedated. They needed to be in an induced coma, or they needed to be paralyzed. So that's one scenario where you have a patient where they are induced and they are paralyzed. And so what will be the problem when they are at this stage? Obviously, the body is in a stasis. The joints are not moving. The muscles are not stimulated. And over a period of time, they will develop some kind of weakness. And what you do then is you want to stimulate the body by providing some proprioceptive facilitation. You wanted to do and maintain the range of motion. You wanted to control edema. So if you look at range of motion and management of range of motion, this then becomes a frame of reference under the scope of biomechanical. So it's a biomechanical frame of reference. If you want to manage the edema, that is also a biomechanical frame of reference. So this is particularly for those patients who are sedated and are not moving. And what you want to do is to prevent problems from taking place. So preventative intervention. So when you start talking about preventative intervention, this then falls on the category of ecology of human performance because of the actual word of preventative intervention. What other models put emphasis on prevention? It's mostly restorative, but when you're dealing with range of motion, edema, then that would be biomechanical frame of reference again. But when a person is sedated and you stimulate the muscles through proprioceptive facilitation and proprioceptive stimulation, this then becomes a concept of sensory motor approaches or neurodevelopmental frames of references. So these would be the classic sensory motor approaches where you're stimulating the muscles and you're stimulating the nerves, the muscles, so that it will, again, you will prevent problems from taking place. So this would be under the concept of sensory motor approach. You can actually stimulate them auditory in terms of the auditory subsystem. So passive stimulation of the auditory subsystem, proprioceptive subsystem, tactile subsystem to maintain and to prevent the integrity of the musculoskeletal status. And what frame of reference would this be? This would be under the form of sensory motor approaches or sensory motor frame of reference. And if you are dealing with, again, auditory stimulation, tactile stimulation, you wanted to maintain that integration. So it is an element. These are elements of sensory integration, frames of reference. So we've tapped on a few frames of references now. Biomechanical frame of reference, sensory motor frame of reference, sensory integration frame of reference, and ecology of human performance. Okay, so you need to read on those four. Okay, so that's one part of that. Now, once they are off sedation and they are in a state where they are recovering, so their consciousness will be altered. They will have some form of problems with regard to their consciousness, and it can be delirium, it could be stupor, it could be coma, it can be an abreaction, it can be coma vigil, yeah? It can be a twilight state. Yeah. So when you're dealing with these things and you want to stimulate the cognition through sensory facilitation, again, there is an element of sensory integration in there. There is an element of sensory motor retraining. This time as well, when it comes to that phase, it now, and you're following and you're monitoring the stages of their reactions, from automatic reactions, from those situations where people are needing postural reactions, and then some manual stimulations, then this then becomes cognitive disability frame of reference. That one gets added. Cognitive disability frame of reference, definitely a winner in here. And if they are up and they are awake and you need to reorientate them, you need to use some kind of reorientations, rational emotive approaches. If, say, people become agitated because of delirium, for example, and you reason with them, you tap onto their reasoning, then this becomes a cognitive behavioral frame of reference. So those are the two cognitive approaches that we are dealing with. And for example, you start to do some problem solving, sensation, perception, understanding. You started using perception as well. This becomes a cognitive perceptual approaches, right? So there you go. Let's have a recap of the frames of references that we need to look after, or we need to learn. You guys need to look at, and you need to learn. You really need to understand this. Biomechanical frame of reference, sensory motor approaches. You need to understand ecology of human performance. You need to understand sensory integration. You need to understand cognitive disability frame of reference. You need to understand cognitive perceptual approaches. You need to understand cognitive approaches. Okay, so we're down to 7 now. 7. And what about behaviors and behavior management? And you control behavior by, again, stimulus response, some of the behavioral techniques that you can use, shaping, for example, in critical care. Then that would have been a behavioral approach. Yeah. So we've gone to 8 now. Now you would have some patients in critical care who may well be neurologically impaired following either a stroke or a head injury or potentially a spinal cord injury. Now, in that case, you would be stimulating the muscles, you would be stimulating, giving facilitatory techniques and inhibitory techniques to stimulate a response or to facilitate, to elicit a response. And that then becomes the classic neurodevelopmental treatment or sensory motor approaches again. And when you go to sensory motor models and approaches, there are a few that is very well used, perhaps not defined, but definitely well used. And what are these? Definitely Bobach. That's a very popular one. But you also have Brunstrom's movement therapy. And then you also have Rudd's approach, the stimulation and inhibition. And then you also have the PNF, the proprioceptive neuromuscular facilitation. So all of those four are the sensory motor approaches. Would you be dealing with psychosocial problems? Perhaps when you're in critical care and you are dealing with spirituality and you wanted to tap into understanding anxiety management, there's a physical reason why people would have anxiety. But if you want to deal with these things, then you can use some psychosocial approaches. Do you want to do like expressive approaches, like art or projective activities, for example, which would be object relations frame of reference, where you get the unconscious out. So you start talking and you let people do some expressions and be expressive, get those things on the unconscious out to the conscious level. Yeah. Object relations frames of reference. Again, behavioral frame of reference, cognitive behavioral frame of reference. This can be useful as well. Exciting, isn't it? And so far, these are the things that I'm seeing. If, for example, you wanted to put on and focus on the process of intervention, where you're following a sequence of therapies, followed by enabling activities, followed by purposeful activities, then this would be occupational performance frame of reference. Yeah. It's interesting. And I can't believe I'm very familiar with a lot of all of these things because all of the new other things that have come out just most recently, it's just an offshoot from these foundation frames of references. Okay. I hope you learned a little something today, guys. Okay. Frames of references to use in critical care. It's not an extensive discussion yet, but I'm just giving you an overview of what can be used. Okay. If I run through it again, biomechanical frame of reference, sensory integration frame of reference, sensory motor approaches and sensory motor frames of references, occupational performance frame of reference, ecology of human performance, cognitive disability frame of reference, cognitive behavioral frame of reference, cognitive perceptual frames of references, the approaches of Bobach, Brunstrom, PNF, and Rudd. There's another one. There's another one in approach or frame of reference that you can actually use. It's model of human occupation. When you start talking about the interest, the values, the personal causation of the person, then yes, that fits in. And if you start dealing with a person's performance, process skills, communication skills, problem solving skills, sensory motor skills, again, model of human occupation will fit it here. All right. Wow. That's just the extensive list, guys. This is more for physical dysfunction and how to manage problems, patients with physical dysfunction. And it doesn't really matter what kind of or critical care a person is in. You just have to do mix and match. You just have to make sure that you identify that there is a problem, regardless of the condition and the diagnosis. If they're in critical care, they're all the same. They're in critical care because the critical organs, the essential organs, are not functioning properly. And what are these essential organs? The heart, the lungs, the kidney. Then again, if kidney is failing, you can just have a dialysis. They don't necessarily have to be in critical care. But all multiple organs working together, then yes. Okay. The brain, the spinal cord. If a brain and a spinal cord is injured, then a person would be very much dependent. Then yes, they could be in critical care because it's an intensive therapy, or it's requiring intensive nursing and medical input. Okay, guys, thank you. I hope you learned a little something. This is how your occupational therapist. This is OT Conversation, but if you look at some of the logo of the podcast, it's Riot Conversation. This becomes a relevant information involving occupational therapy. Riot, OT Conversation, Riot being this episode is a relevant information regarding occupational therapy. Until next time, bye.